Well, thank you very much, Julian. Much appreciated there for giving me that introduction as well. So my name is Lauren Moorcroft. I'm a GP partner at Brookvale Practice in Holton. So Matt's old patch, as he talked about. So I'm part of the Runcorn PCN, which is 6 practices locally. And our practice has around 8,000 patients, just to give you some context. And I've been asked to come on here today just to mainly talk about our practice journey with the proactive care at home frameworks, and how we've kind of started to embed those protocols and adapt them locally. So just to give you a bit of context of where this all started. So back in middle of last year, obviously we were mid-COVID, and I was tasked at that point with recalls for asthma. So my cough area was asthma. And that's where this kind of journey began. I'll talk to you in turn about how this then progressed, because from asthma we then moved on into COPD. My first follower was our asthma and COPD specialist nurse here at Brookvale, and she was interested in what we were doing. And then from there, we are also blessed with a practice nurse who is extremely qualified in diabetes and manages our diabetes patients, so she became quite interested in what we were doing, and alongside that our hypertension work followed. From that we expanded this into our one-stop process, and I'll expand a little bit more on that later, but as a quick overview, historically at Brookvale for a very long time we've been doing a one-stop process, which is a clinic basically. So pre-COVID would run on a Wednesday afternoon, and was aiming at getting our most frail and our most vulnerable comorbid patients, and trying to literally do everything at once and capture people who, for instance, you'd only manage to get into the surgery once a year. So and then moving from that, our journey has moved on a little bit more now into lipids, particularly secondary prevention, and also looking at atrial fibrillation. So I can talk a little bit around the tools that we've developed and taken from UCL partners and kind of moved into our practice. So basically, just to give you a context from the beginning, as I mentioned, my area at the very start was asthma, and in Brookvale Practice, at this point in December, just giving you a point there to refer to, as I'm sure all practices were at that point, we had overdue recalls. So at that point we had 600 odd asthmatics and about 100 were overdue, which is not bad. We did carry on doing a lot of remote reviews and what we could do through the pandemic. We never had a pause really here. So at this point, I was interested in how we could, particularly with a respiratory group, how we could do chronic disease reviews safely and appropriately during a pandemic, and also how we could prioritise what we were doing, recognising that we did have to address a backlog and it was potentially only going to get worse, and we did need to rethink what we were doing really. So at this point, the UCL frameworks kind of just dropped into my inbox, and just luckily, and I was really interested in them and had a look at them, and then downloaded the free resources which Matt mentioned earlier. So there's free EMIS searches that you can get from UCL, and as Matt's talked about, they then have these clinical priority groupings. So for asthma particularly, you've got your group 1, group 2 and group 3, and they're, group 1 is your biologics and your people with their lots of steroids and antibiotics, whereas your group 3s are, say, just a SABA and that's it. So that's your clinical priority groups, which I found really helpful. So that split out our patients first, and I could look at then who was overdue in those groups, and actually for group 1 just do a double check for some of them as well, which was really helpful to be able to see that quickly, and the numbers are on there just for reference for our practice. But what I quickly recognised was, and this was obviously at the time becoming more and more discussed, was the idea that we did really need to now address these inequalities in access to care. And so what I then produced on top of this, just being an amateur EMIS search person, I overlaid some searches there looking for BAME, deprivation, and that was initially postcode search. It was quite crude, and I very quickly realised that a lot of our postcodes here are in deprived areas. It didn't really help me stratify. And then asylum seekers, and that mainly came from a local context here that we have. During the pandemic, we've had a kind of contingency hotel accommodation locally, so I wanted to pick up those people as well. And then I added in people who were missing reviews for more than 2 years. And then I added in our one-stop, and we've used a one-stop code for a long time, which is chronic disease monitoring, and that helps us pick up these patients that we've agreed as a team need to be seen in that process. So I overlaid the clinical groupings with this kind of vulnerability grouping, and then I came out with my own risk areas. So I labelled them high, medium and low, and separated out our one-stops. And then I could obviously look at the ones that were overdue their review in that. So the process was really useful for prioritising my workload in that QOF area, but also finding these vulnerable patients as well. And for case finding, it was incredibly helpful too, because I found that I picked up people who had just missed their code and not been put on correctly, and it was really quite enlightening. So from that, I then overlaid, as per the UCL process, triaging out depending on their ACT scores. So here locally, we use Accurix, as I'm sure a lot of people have done, and we sent out the florries for those who had mobile numbers. So just briefly, this is a screenshot really of our protocol that I developed then based on what we were going to do about these patients. So on the left, you can see our highest risk, and led by the UCL protocols and our own local kind of discussion as a team. The idea was that we would basically prioritise this group, and we would get them seen very quickly in our so-called virtual clinic at that point, and have an extremely low threshold to get these people in face-to-face based on either clinical or social or complexity reasons. The median group, of which we had 48 at that point, we had an admin lead who was excellent with developing the pathway here. She sent out her ACT florries. I came up with a watertight process for her with, if people came back with concerning responses such as I've got chest pain or whatever, she had a clear escalation protocol. And then we were able then to triage out a little bit more. So we were able to pick up those people who were very poorly controlled, under 15 on their ACT, and people who were actually doing relatively well, and we could potentially park for a later date. And for the low risk, there was the idea that we could look at sending the self-care information, just checking their smoking status, using a low risk code, and then so that we could refer back to it later, and then we could potentially sign off that as a review. So some learning from that was the peak flows being issued in advance through our EPS was extremely helpful, because we found a lot of people didn't actually even have them, didn't know how to use them, and we could talk through that. We had the results there available as soon as the clinician could discuss with them, and generally that went down really well with patients and with the clinicians. Our admin lead was making sure that if they had chronic disease bloods, that was done in advance, and we were sending out afterwards, inhaler videos via Accurix, and Accurix asthma plans for those who had mobile numbers and were digitally savvy enough to use it. So our respiratory lead nurse here became then very interested in what we were doing, and wanted to basically adopt a similar process. So we got our heads together, and helpfully she has the same admin lead for her QOF area. So it worked quite nicely because that person was already quite au fait with what we were doing, and felt comfortable with it. So again, we looked at the UCL protocols. We had a little look at our EMIS search that we've downloaded for COPD from UCL, and that put us into our clinical priority groups. So quick overview, you've got your MRC 4 to 5s and core pulmonalis and things in group 1, and you've got people with exacerbations in the last 12 months or prophylactic antibiotics, they're all in your group 2. And then it didn't really help us so much with the clinical triage here for group 3, because we found that we only had one person out of 5 in total in that grouping. So again, I overlaid my kind of amateur social complexity searches there and picked up our missing reviews, our one-stop patients and other groups. And then we could then put them into our high, medium and low categories. And similarly, we then overlaid the CAT accurates. And again, if somebody didn't have mobile or was not digitally savvy enough, our admin lead was able to do this over the phone with them using the freely available online resources. So similar to our asthma pathway, we then popped this into a protocol that I made, and similarly we triaged out our high, on medium, further triage using the CAT, and making sure we had a follow-up for that, and we took out our low risk as well in the context of the pandemic. So feedback from that from the clinicians was, again, it was really helpful to have the peak flows issued in advance. For those that had mobiles, we were sending the link to how from the NHS Net website of how to use your peak flow. We got chronic disease due bloods done in advance, and our culture here is generally a one-stop approach. So if a clinician's reviewing and they have that in their armoury, they will do the other chronic disease reviews at the same time. So that was really helpful. And the inhaler videos that stand for asthma obviously are helpful for COPD as well. So moving on from that, the next phase in our journey expanded basically into our again, we're really lucky here with our practice nurse who specialises in diabetes. And alongside her is our extended practice HCA, who takes the lead for hypertension with appropriate escalation pathways and has done for a very long time. And similarly, they became quite interested in how to triage their workload, how to make sure that the time that they did have was being given to the most high-risk people, really. So again, we went to the UCL searches, I downloaded them, popped them into EMIS, and we had a little look at our clinical risk groupings, and then we got heads together. I drafted a protocol of what we were going to do about it, and we filtered out our overdues and we filtered out our type 1 diabetics. We did a similar process with the hypertension, and again, all these clinical priority groupings are freely available online through UCL. You can have a little look at how they do these groupings, but we find them really helpful for filtering out people who are at highest risk. And then the light bulb moment that came on for me here was really fantastic feature of the diabetic UCL searches. They actually have a complexity overlay built into it. So it filters out for you your, people with alcohol use or homeless, asylum seeker. It's a very frailty, for instance. It's a really good search that bumps up your risk grouping depending on that kind of vulnerability or comorbidity search. So that was a bit of a light bulb moment for me, and I then went back to the other searches and managed to kind of, in my amateur fashion, copy and paste those complexities back into our COPD and asthma searches, which really helped us, and gave that feedback as well at the time to Julia and Rhiannon that wouldn't it be fantastic if we had this for all of them. So using that kind of overlay that was already built in and the feedback from our resident specialists here, we came out with our high, medium and low grouping, which also put in people who've been missing reviews and were generally poor attenders as well. And then we came out with these figures which massively triaged workload for our clinicians and meant that we were focusing really our precious time on people who we felt were clinically or socially most at need. So similarly, we hammered out, just a draft protocol of what we were actually going to do when we got these people in. And again, we had a low threshold for face-to-face once we'd done an initial phone call with the high-risk people. And similarly, as things progressed, we developed a joint clinic for our diabetes nurse and our healthcare assistant who takes lead with hypertension. Based on their own ideas from what they'd seen was working and not working, and that's we're finding that really helpful because we can triage out what needs doing through our HCA and our admin first, and then they come to our diabetes practice nurse once all of that's been completed, and it really helps also with people who we're not getting as much done with in advance for chaotic lives or whatever it is. We can then capture them and do that on the day. So moving on to what came next. So Jane is going to talk to you a lot about the BPQI tool, and has only just been here this week. Thanks for that, Jane. But this was again looking at how we can really focus in on our highest risk patients, particularly hypertensives. And the BPQI tool is just another part of our armory now that we're going to use. So there's an EMIS dashboard that helps us again filter out by things like our most socially complex patients or people who are needing the reviews because of their clinical parameters. And there's also a consultation template alongside that, which we're now going to start using and trialling. And our healthcare assistant, Jen, is a big fan of it now because she said that she loves the pathways of the initial diagnosis, which she has strong support from our GPs and nurse clinicians here with, but it now helps her kind of record that all in one place for her, and also training support, which Jane has been here this week to do with us and is ongoing supporting us with. So I'll briefly talk about our one-stop process, and this is how at Brookvale we've done things perhaps a bit differently, and been looking really at comorbidity. So our one-stop register, there's from January was 1,782, so more if you include our local care home patients and our housebound patients, but we do tend to have a separate process for them with how they're managed. And what I found really useful with this process was the case finding aspect of the searches that we've done for the other conditions, because we were picking up high risk or complex vulnerable patients through these searches that should have been one stop really, and due to not being our best attenders, which often goes together, had not been in that process. So it was actually quite powerful to go through this process, and we could then code on our chronic disease monitoring code and get these people into our one stop process. So pre-COVID, that would involve getting someone in face-to-face on a Wednesday afternoon in a clinic run by our nurse partner and practice nurses and our HCA, and everything was done at once. So if they would do a Spiro, that was done, an ECG, urines for ACR, and all their chronic disease reviews at the same time. And then our nurse partner would be mopping up all the things that these patients were saving for the day that they were coming in for their review. So obviously with COVID, that all went completely out of the window, but very quickly we felt like our one-stop patients were really missing out, and we needed to do something, but not putting them at risk and bringing them in unnecessarily. So all the learning that we've taken from our other pathways here, we then put into one stop and came up with this process where we had bloods done in advance, ACRs done in advance, home monitors if they had access to one, or we can loan one out to them. We were checking smoking status, we were getting peak flows out, and we were doing as much as we possibly could before a phone call to them to do as much as we could with their chronic disease review over the phone, and then converting that to face-to-face for any acute issues or things that just had to be dealt with face-to-face or were more appropriate because of, for instance, dementia or other vulnerabilities or communication issues. So that process worked quite well. I'll just have a brief note on that though, which is our learning here in practice has been that really the power of this work so far is to keep our face-to-face appointments for these people. So now the context has changed. Obviously in the COVID pandemic, we have most people coming up to their second doses, cases are coming down. And overall, our feeling is these people need to be face-to-face due to clinical complexities and social vulnerabilities. So they are now, our one-stop clinic has reverted to face-to-face. And as long as it's safe and the patient's happy to, they come in and we get absolutely everything done as we did before. But the power of using the other pathways for the other conditions means that when we feel it's safe and appropriate, we are now triaging out into more telephone reviews and low risk type reviews, and that's giving us the time back again to focus on these people. So really the pathways have helped us focus in and prioritise our workload there. So I'll talk about briefly the lipids and AF work, which we're just starting off with now. That's all grown up out of this really, and the AFQI project has already started in Widnes, and I've now signed up to get it going here. And you can see from our numbers there how it's going to help us with our overdue reviews, but also prioritising by clinical groupings. And then alongside that, we're working now with our meds management team on a lipids optimization project. I'm really excited by this because we've basically got 3 fantastic meds management pharmacists on our extended team, basically. So they are doing a pilot for secondary prevention work. And again, the UCL searches I popped into EMIS for them have come out with our clinical groupings. And they're now starting with secondary prevention, looking at those patients and doing the reviews with them using Accurix, using our EMIS system, and then liaising with me as lead GP for any kind of prescribing mentoring and also reviews that these patients might need coming out of that. And I'm really excited about that work because we can only learn from it, and also once that big piece of work has been done, there's an opportunity there that we can do that on a rolling basis and move into primary prevention. So in summary, I think our journey has been, moving from a single condition with asthma and then through those other conditions and our one-stop process. I really feel like post-COVID, we're in a better place now to prioritise our workload, and that's been a real key thing for the clinicians here. Look more and more towards educating our low-risk patients about self-care, remote ways of keeping in touch and assessing, and basically triaging out our low-risk patients and the people who are digitally savvy enough to manage that way. To make that work properly, I think workforce training is really important, and that's what we're now working on with Jane supporting us with that. So our front desk team are now getting a bit more support in how to support patients with things like peak flows and blood pressures at home, and do that in a safe manner and escalate and keep that safe when needed. And also the thing that we've noticed that we've got to be really mindful of is what Julie mentioned with the digital divide. So we've been very careful here that for people who have got any barriers to access things digitally, we are taking the path of face-to-face or just reaching out with a phone call first rather than assuming that kind of digital access. And that particularly applies to the rising numbers of people without English as their first language in the area. But the thing that really is impressed upon us is how this work has meant that our one-stop patients and our outreach work has really been able to give that time basically and reach out to our highest risk patients.